Okay, hello everyone. We're going to talk about Guillain-Barré syndrome today, what it is, what the pathophysiology is behind it, the causes, and of course we're going to treat about how we can diagnose it and treat it. Now, first of all, Guillain-Barré is an autoimmune disease. It's producing antibodies that target the basic protein in the myelin sheath of peripheral nerves. So this causes progressive paralysis, but we're going to talk about this more when we talk about the symptoms. It's also called rapid onset of muscle weakness, eventually leading to paralysis in some very severe cases. So basically the causes of Guillain-Barré are largely unknown, but in many cases it's been linked to previous infections which are gastrointestinal or respiratory in nature. So different agents or different microorganisms can be linked to this, one of them being Campylobacter jejuni. We're going to talk about it in an example later when we talk about the pathophysiology, but there are also more others like Haemophilus influenza and some viruses like the Epstein-Barr virus or cytomegalovirus. Now, other rare causes of Guillain-Barré are previous influenza immunizations, some drug-induced cases which are linked to antidepressants such as zimmelidine, and of course trauma or previous surgery. Now, when we talk about previous infections, this is very important to ask the patients when we take the anamnesis, because many patients, 70% of the cases, will report having respiratory or gastrointestinal infections prior to onset of this disease. So Campylobacter jejuni is one of the most common cases, or one of the most common causative agents, and the mechanism of action or the reason why this is happening is linked to a mechanism called molecular mimicry. So in this case we have the lipopolysaccharides on the outside of Campylobacter jejuni, which on the outer membrane, which is triggering a immune response because it's a foreign antigen. So the immunity, our immune cells, mostly macrophages but also T lymphocytes, will attack this lipopolysaccharide on the outer membrane, but at the same time also tissue structures that resemble this lipopolysaccharides. And in that case, it's gangliosides, which are linked to the peripheral nerve membrane in human nerve cells. So these antibodies will attack the myelin sheath and gangliosides, and in that case, in peripheral nerves, we will have a demyelinization. So this is basically making nerve conduction more inefficient because the nerve conduction or the current is disrupted, which means that we have the symptoms which we're going to talk about later, which is linked to peripheral nerve damage or demyelinization. So this whole process linked to molecular mimicry is also called cross-reaction because we have a similar antigen which has been attacked by our own immune system. Now, what are the clinical features or the symptoms, how we can recognize Guillain-Barré? Basically, as we said before, previous infections of the gastrointestinal respiratory tract can be a hint because patients will report having it, let's say, a month before onset of this disease. So it can be very helpful if the patient reports such an incident. Now, one of the first signs of Guillain-Barré is the so-called acroparesthesia. So this is basically burning, tingling, or any similar sensation of the distal extremities. It can be also reported as numbness, usually in the lower extremities, but it can happen in the upper extremities as well. And what's very important is that those signs are symmetrical. So this happens on both sides of the body and it's ascending. So the patient will report these problems on both sides. And first they begin more distally and then they ascend gradually towards the torso and in the upper extremities. So besides acroparesthesia, we also have something called hyporeflexia, or in some cases even total areflexia. So that means that reflexes of the patient will be diminished response upon stimulation, or in some cases maybe even completely absent. So this ascending sensory symptoms can be also accompanied by muscle weakness, which is considered the second sign of Guillain-Barré. Again, it begins distally from lower limbs. Both sides are affected symmetrically, and the weakness can be gradually increasing as well. Most of the time, the progression varies between 1 to 4 weeks. Now, Another sign which is possible in some cases is paralysis of cranial nerves. So in most of the cases this is presented as facial palsy, so the facial nerve being affected, but we can also have bulbar nerves affected, such as the vagus nerve, but oculomotor nerve as well. So many cranial nerves can be affected in approximately 50% of the cases. Now, other clinical features, autonomic dysfunction, which is basically pretty much presented as, in many cases, orthostatic hypertension. Orthostatic hypertension, dysregulation of blood pressure, tachycardia. Those are signs that can be present as well in many cases. And if Guillain-Barré is left untreated, or if it progresses to a more severe form, it can lead to life-threatening outcomes linked to respiratory paralysis, because the diaphragm and respiratory muscles are not excluded by this pathology, and this is then considered a neurologic emergency. This happens rare, however, but it's one of the most common causes of death in patients with Guillain-Barré, also linked to respiratory paralysis, but we're going to talk about this later when we talk about treatment. Now, how can we diagnose Guillain-Barré? Pretty much everything I've mentioned before linked to the symptoms will be presented upon neurological examination. So the clinical picture will be, again, muscle weakness, ascending paresthesia, which is symmetrical on both sides. The patient will report muscle weakness, which is gradually increasing, let's say from 1 to 4 weeks. This can vary in many cases, and hyporeflexia, or in some cases even areflexia, coupled with sometimes facial nerve palsy or affected cranial nerves as well. Now, what we can use, except for neurological examination, is the so-called EMG, the electromyography. So this is something that's measuring the conduction of the nerve. So, for example, stimulation of a muscle will lead to its, let's say, response or contraction. But in case of Guillain-Barré, due to this process of demyelination, the nerve signal is basically inefficient or less efficient. And that's why on EMG, on such a device, we will see that the conduction speed of peripheral nerves is decreased. Okay, and we can also take lumbar puncture or cerebrospinal fluid to confirm the diagnosis. Many cases will have dissociation between protein and cell levels, increased antibodies, basically peaking in about 4 to 6 weeks. But in about 10% of the patients, the spinal fluids may remain normal, but however, in most cases we can detect antibodies that are directed against gangliocytes. So this will be a key feature to diagnose Guillain-Barré syndrome. Now, we also have to talk about differential diagnosis. These are some diseases which resemble Guillain-Barré, such as myasthenia gravis, botulism, or HIV-associated polyneuropathy. In some cases, and of course spinal cord injuries, in some cases can mimic Guillain-Barré syndrome. Now, the prognosis of Guillain-Barré is generally favorable. Most patients recover from Guillain-Barré without any residual symptoms within a few months, up to 2 years, but others remain with residual symptoms or even a chronic version of the disease which is relapsing. Okay, now finally we talk about the treatment. So what do we do in a patient with Guillain-Barré? Pretty much all we can do is monitor vital functions to be ready for reanimation if needed. Reanimation procedures, intubation, pulmonary ventilation. This is when the patient suffers from respiratory arrest. And in cases where swallowing is impaired, we also of course need to place a gastric tube. Now, because many of those patients are immobilized or generally can't move a lot, they are under a lot of bed rest, which means that they're immobilized. So in order to prevent pulmonary embolisms, we need to give anticoagulants as well as a prophylactic. Okay, but in general, the main therapeutic strategy is high dose of intravenous immunoglobulin at a dose which is given for 5 consecutive ways to block macrophages and other immune cells that mediate demyelination. And this is, however, given in more severe cases where the inflammatory process is very severe. And of course, as I said before, the Guillain-Barré syndrome is rarely lethal. It normally has a benign course and most patients recover from it. So thank you very much for your attention, guys. Thank you for clicking on this video.